bipolar affective disorder is a major mental health condition that's characterized by mood dysregulation. So when we say mood, there are two types. There's mania and there's depression. And we're talking about opposite ends of the spectrum almost, right? Where in depression, we're all aware of what it is. It's low mood, don't feel like doing anything, being sad, losing interest in everything that you want to do or you like to do before this, helplessness, hopelessness, worthlessness, in extreme cases, suicidal ideation or even attempts, loss of appetite, you don't feel like eating or you overeat maybe, comfort eating, can't sleep or you sleep too much because you don't have energy. So mania is not the opposite. It would be wrong to say the opposite, but it is almost the opposite, where it's the extremes of the other extreme of everything that I just described, where it's extreme levels of energy, grandiosity, believing that I'm capable of anything, irritability, because everything seems just too slow. People seem too slow. So even when you talk to me, I might just get irritated because it's too slow for me. Risk-taking behavior. So maybe whether it's sexual risk-taking or gambling, taking risks with money, risk-taking behavior, substance abuse even. And also, like in depression, there's an inability to sleep, but in mania, there's a decreased need for sleep because there's so much energy, I don't need to sleep. I may feel like I don't have time to eat and I don't need to eat because I have so much energy again. Usually we see alternating periods of mania and depression. We may not see an episode of mania for years sometimes. So you might first see an episode of depression, the person may come in for support, and then years later when we're talking to that person about maybe their past, you may find that they explain a situation which is very uncharacteristic based on what you know of this person. So that's when you might kind of wonder if BPAD might be a diagnosis that you would apply there. And then generally, according to the ICD and the DSM-4 or 5 now, we look at least 2 episodes need to be present before we give a diagnosis of BPAD. So it might take years actually before we diagnose a person. Research has found that BPAD is one of the most stigmatized mental health conditions, and for all good reason, because one is we don't know enough, or when I say we, people in general, don't have enough awareness about what BPAD is. It's a lot better now thanks to organizations such as yours, other institutions that are doing great work educating the public about mental health conditions. So it's a lot better than it used to be. But still there is there's a significant gap in awareness about what BPAD is. And some media doesn't help also, because books and movies tend to portray people with BPAD as dangerous or toxic, as individuals who don't contribute to society in any way, as problematic, serial killers even maybe. So because of that, and we consume so much of this, society tends to see those with BPAD or any mental health condition with a very skewed perspective. And this lack of awareness combined with maybe our attitudes, our perceptions, together results in discriminatory behavior, which can be detrimental to a person's well-being. When society tends to discriminate against us over and over again, or stigmatizes us over and over again, and we constantly hear these negative messages about how useless I am, how dangerous I am, how I will not be able to contribute to society in any way, eventually I will start internalizing this. And it's normal, it can happen to you and me, where we will start, if someone keeps telling us that we're useless or worthless, we have no value to this world, if we hear it often enough, we will start believing that it is true. And the moment we start believing that it is true, and the thing is, these messages are generally very subtle. It's in passing, it's a joke, it's a random comment, it's someone not allowing us to take responsibility for something because they say, oh, it's okay, you won't be able to do it, or it's too much for you. And hearing these little subtle comments can really affect us in a very deep and profound way, where then we start believing it, we start doing it to ourselves. It becomes our own, we start wearing these tinted glasses through which we look at ourselves now and start believing that I am not capable, I am not good enough, I can be dangerous, I shouldn't be a part of this person's life because I am a problem. Eventually, self-stigmatization leads to what we call learned helplessness, because the self-fulfilling prophecy that has now reinforced my belief that I am not good enough then results in me thinking I'm not capable, so why should I even try?
We see a lot of companies advocating for mental health and well-being within organizations. But the question remains as to whether employees are actually using these services, if you will, and to what extent. So, for example, there are organizations that have employee assistance programs, but people don't use them because they're afraid that their confidentiality would not be respected, that anonymity would not be respected, and also the fact whether they'll be judged. So when we take Sri Lankan culture and especially the workplace, we are very, I would say, passive in that stance to reach out for help, to communicate. And that's something that's innate, that we have learned as a society. But also, we don't want our self-perception to be tainted. So a lot of individuals don't ask for help, even if their companies do offer it. And the companies do offer it, need to make sure that they do provide a confidential, non-judgmental, private service. And sometimes it's hard to see that. So you can understand why employees may not be actually reaching out to their heads of departments. Now, if we take the persistent instability that one has about themselves, and if it affects relationships, if they're impulsive, right, constantly needing validation, or has bursts of anger, unable to regulate their own emotions, then that's going to affect their relationships at work. And of course, with the dip in mood, they're not going to be able to kind of function as as they would normally perform on a day-to-day basis. And that is a problem because so if you have somebody who has an episode of mania, you're looking at people who are highly alert, highly active, and they go into a creative mood, which is all good. But do they have a predefined set of goals to achieve during that period? If not, then yes, you're going to have heightened kind of action, but is it regulated to achieve the goal? So that question is there. When one does fluctuate between depression, if it's depressive, bipolar, or mania, which is constant, self of grandiosity, need to control sort of personal and professional relationships, then there's a sense of that insecurity which is there amongst them, which hinders their relationships because it's about controlling the relationships as well. So that could kind of alert the other person if it's a co-worker, and that person might move away. Now, this is going to cause another cycle of trauma for the individual who has bipolar. So it's about then having the necessary mechanisms in place to help the individuals to regulate their emotions. And if the episode is really bad, then to take the leave that they need. So that is one way of looking at it. And also, how is their work like? So if they're in a highly pressurized job, then do you have enough leave for them? Do you have somebody who's constantly in touch with them, checking in on them, so that they feel that sense of reassurance, validity, sense of security, that somebody is there to protect them, so that they're not left in the dark? Because the lack of communication is one factor that actually triggers their sense of vulnerability. When we look at mental health and any form of reform, we're looking at policy change. With policy change, we look at three areas. How do we prevent mental ill health? How do we promote good health? And also, how do we adhere to best practices? So prevention, promotion, and also awareness, education. So there are three factors that actually prolong and even, I would say, is detrimental to organizations and individuals. That's lack of awareness and education, stigma, and also the fact that culturally we are not open enough to reach out because of the stigma. So what you're saying is very important, because a policy change would make sure that people actually speak and build that awareness that we need, whether it's at a community level or whether it's at an organizational level. Now, when we zoom in on the organization, if leaders speak out, and if they really want to have diversity and, in this case, inclusion, I would look at what health coverage are you providing, right? Because when we talk about health, we're looking at the definition according to World Health Organization includes mental, physical, and social health. Organizations cover health, physical health coverage, but not mental health, right? So a lot of, if we do look at individuals who have a lot of musculoskeletal problems, gastrointestinal problems, even ulcers, when the doctors do look at an in-depth, deep dive, sometimes they don't find an underlying grave condition, and they boil it down to irritable bowel syndrome, chronic fatigue syndrome, and other conditions that aren't physically really grave, which means there is a mental health aspect to it. So that's what we call somatization. When we don't address mental health, it manifests in physical forms. So that is why I think we need to look at mental health, covering mental health as well, because in the end it's a part of health.